Good afternoon. Welcome to the Western Region Training Center Health Services Research Seminar Series. Welcome to the first seminar of the series. Today we have Dr. Daniel Fuller presenting a seminar on built environment, transportation systems, and public health. Dr. Daniel Fuller has a PhD in public health from University of Montreal with a specialization in health promotion. He is currently a Canadian Institute of Health Research and Saskatchewan Health Research Foundation postdoctoral fellow working in partnership with Dr. Corey Neudorf and in the Department of Community Health and Epidemiology at the University of Saskatchewan, and Dr. Aaron Strumpf in the Department of Epidemiology, Biostats, and Occupational Health at McGill University. His research interests include population health, natural experiments, transportation, and health inequalities. He is currently working on a number of grants, including an international evaluation of the impact of public bicycle share programs on cycling and collisions on North America. So please welcome Dr. Daniel Fuller.
Thanks, everyone. So a couple things before I start. We're having some browser compatibility issues, so this logo on the bottom is not how it should be, but we're going to live with that for today. The second thing before I start is if you have questions or if you have comments or anything, please feel free to interrupt me during the presentation, and we can answer questions, we can have a discussion. Hopefully I won't just stand up here and talk for 40 minutes and then you'll have questions at the end, so hopefully we can have a bit of a discussion. So my first question for you is, how did you get here today? You may or may not have taken the bus, but who drove their car? Yes? Who rode their bicycle? Who took one of the yellow U of S buses? Anybody? No? Any other modes of transportation out there that people took? Walking? Okay, walking. I forgot about that one. Good. Okay, so we have a whole bunch of different modes of transportation that we use to get around, and probably very few of us are exclusively walkers or exclusively cyclists. We all kind of use the modes as need be to get where we need to go. Would people agree with that? Yes? Okay, good. So my second question for you before we start is, do you think that your transportation behavior is related to your health? Would you say yes? Okay, would you say no? Who says no? I say no. Okay, second question is, do you think your transportation behavior is related to population health? So not your health, but the health of the population on average. Yes? Okay, I'm preaching to the converted here, so that's nice. So there's three kind of concepts I want to talk about today. The first is a population approach. The second is this idea as an idea of vulnerable populations, and a third is an idea of co-benefits and co-risks of transportation systems. I'm going to try to explain these concepts using papers. So those who are in the Western Regional Training Center program, you received those three papers and hopefully you've read them. But if you haven't, we'll kind of go through them. So we're going to try to explain those three concepts using three papers, and then try to think about how we can continue to study transportation systems and how we can study the relationship between transportation systems and health. But first, all of my research is sort of based on this notion of population health intervention research. And this is Ha and Patvain. And what population health intervention research is it involves use of scientific methods to produce knowledge about policy and program interventions that operate within or outside the health sector and have the potential to impact health at the population level. So there's sort of two key things that we need to think about there. Three, I guess. Scientific methods, we like those, I like those. Interventions and programs that operate within or outside the health sector. I'm particularly interested in the transportation system, which potentially influences health and is outside of our sort of health sector interventions, and have the potential to impact health at the population level. So we're thinking broadly about health and how we can change the health of populations. So that's sort of the pre-ramble. The built environment. Public Health Agency of Canada defines the built environment as part of our physical surroundings and includes buildings, parks, schools, and systems, road systems, and other infrastructure that we encounter in our daily lives. We are basically interacting with the built environment all the time, every day. The room that you're in right now was designed by somebody. The chair that you're sitting in was designed by somebody. Everything that we interact with has been designed so that to make it easier or for some reason, right? Arguably, even when we're walking in PA National Park on some trail, we're still interacting with the built environment because somebody built that trail, right? Some planner, some engineer designed a trail to make it easier for us to get around, to protect the environment, right? So we're almost always interacting with some form or another of the built environment. That makes studies of the built environment particularly challenging, right? When we think about our epidemiologic methods, when everyone is exposed, it's a lot harder to study that type of exposure, right? And we need to try to find sources of variation within everyone who's exposed to try to unpack what's happening. So some of the people from my Public Health 840 class are here, and they're all smiling because we talked about that last week, so that's good. But what I'm going to talk about today is how we can sort of try to do that, and some studies that talk about that a little bit. So the first paper I'm going to talk about is one that myself and my colleague Patrick Morancy wrote. Pat's got 2 papers in this presentation, so he's doing good in that area. And the paper I'm going to talk about is a population approach to transportation planning, reducing exposure to motor vehicles. And this is sort of an idea that Pat and I had to think about how we could apply population health thinking to transportation behaviors, and particularly injuries due to collisions with motor vehicles or between motor vehicles. So one of the crucial things when we're thinking about population health and thinking about population health intervention research is this idea of the prevention paradox. So a preventive measure which brings much benefit to the population offers little to each participating individual. So this is from Jeffrey Rose. People might be familiar with his work. And transportation, generally speaking, is pretty familiar with this, right? What's a big prevention paradox intervention in transportation that happened, I don't know, around the 50s? What do we all do when we sit down in our car? We buckle our seatbelt, right? Very, very little benefit to each participating individual, but massive benefits to the population, right? We all just get in our car and buckle our seatbelt. We don't even think about it. But there's other areas of transportation where the concept or the notion of the prevention paradox is less applied, and that's what Pat and I are trying to do in this paper, is sort of start to think about that. The other thing that we want to think about when we think about population health intervention research is the distinction between the causes of cases and the causes of incidents. So just in case, a little reminder, a case is an episode of disorder, illness, or injury affecting an individual. I am in a car and I get hit by another car. An incidence is the number of cases of a disease that come into being during a specific time period. So how many people get hit by a car in a given time period. And what we need to think about when we're thinking about this population perspective is that what causes a case, what causes me to get hit by a car, is completely different than what causes the number of people who get hit by a car. And we're trying to sort of make that jump between why people get hit by cars to why there's 30,000 deaths per year in the US due to motor vehicle accidents. So what have we talked about? We've talked about the prevention paradox. We've talked about causes of cases and causes of incidents. And here we're talking about the majority of cases occur in individuals at average risk. So what we need to think about, this is a chart that we put together that's actually in that paper. So on the y-axis, you see different modes of transportation. Bus, vehicle, walking, cycling, other vehicle, that includes motorcycles, okay? We see the number of deaths per year. This is the US data. On the x-axis in black, and on the x-axis in Y, we see risk per 100 million person trips. So here we see, sort of in red, the risk of death going up in black. So we say, okay, for motor vehicles, there's about 10 fatal collisions per 100 million person trips. For walking, there's about 15 fatal collisions per 100 million person trips. For cycling, there's about 22, 25, and for other vehicles, there's about 30. So if I take my walkers, let's say they're at average risk, 15 deaths per 100 million person trips. Does that make sense? Yes? So if I just if I forget about my black and I just look at my red, what am I going to conclude from my analysis? What would my intervention be if I was looking at the walkers, cyclists, and other vehicles compared to motor vehicles?
Cycling and the other
Right. So I would conclude that walking, cycling, and motorcycles are a lot more dangerous than vehicles, so we need to do something to protect walkers, cyclists, and other vehicles, right? That's totally a reasonable conclusion. And that's the way that we typically think about preventing collisions, right? Preventing injuries and deaths in motor vehicles. But now if we add on our black y-axis here, deaths per year, we can see that despite being at a slightly lower than average risk, let's say, motor vehicles contribute the vast majority of actual number of fatal collisions, right? About 90% of them. So when we start thinking that way, we need to start thinking, how can we make it so that we have less collisions overall, regardless of vehicle type? And then how can we make it safer for those specific types of vehicles, walking, cycling, that are more risky, quote unquote? Okay, so we're trying to think about the total risk, the absolute number of cases, and the relative risk, the difference between risk for vehicles, walking, cycling, other vehicles. Kevin's here, so that's good. He can. So this is a figure from the paper. So here we're looking at, on the y-axis, traffic volume at intersections, and on the x-axis, number of collisions per year. Sorry, flip that around. This is what's called a safety performance function. So here we can see sort of a slightly nonlinear relationship between the number of collisions and the traffic volume at intersections. As number of collisions increases, as traffic volume increases, number of collisions increases, right? So typically what we do and what transportation planners do is they say, okay, this is our standard curve. We're willing to accept all of the risk in this curve. Except if an intersection is deviant from the curve, we'll say that intersection is deviant. We need to bring it down closer to the curve. Okay, so we need to say this intersection is too risky. We need to get it closer to the curve, right? We need to make it within some measure of our curve. But that's exactly our sort of high risk approach. That's like saying you're obese, you need to lose some weight, right? But it doesn't address the causes of incidents. It just says we have one specific case here that's too dangerous. We need to make it safer. It doesn't address the fact that there's all these collisions happening. So what Pat and I started thinking about was, if you wanted to act on the causes of incidents, the number of cases, actually the idea that you have to have is you have to shift the entire curve. So you have to make every intersection safer, just a little bit, not a lot. And you'll be able to shift the curve to make everyone safer. So what we wanted to do is sort of put some numbers on that. So this is data adapted from a Beck et al. Study. Here you see sort of that data that we saw in the figure. Person million trips, so this is the US. Number of person million trips, fatal risk per 100 million person trips. Here's the status quo. So here's what we have for deaths, okay? About 30,000 in vehicles, 5,000 for walking. Motorcycles are so dangerous, it's ridiculous. And then we said, what if there was an overall 4% reduction in the risk in each of these groups, right? Pretty simple little question. And we have, in the paper, we have a couple more scenarios. But how many deaths would we save if we had a 4% reduction in risk? And we estimate about 1,300 fewer deaths for motor vehicles, 200 for walkers, 28 for cyclists, 2 for the bus, and 124 for motorcycles. So we're sort of trying to think about how can we make it just a little bit safer for everyone, and what would the impact be? What do you think we would need to do to make every intersection 4% safer? Any ideas on that?
Slow down. Sometimes there are delays in the lights, so everything's red for a second and then the green comes on. I don't know.
Okay, so
design features.
Okay, so we could use design features to try to make the intersection 4% safer. We could have some features of the light, right? Any other ideas? Okay, so we could add signs and pavement markings. Pavement markings in particular are very, very good at that very small change in risk, right? So instead of having just a painted crosswalk with one white line and another white line, we have a bright green crosswalk, right? That would get you there. That's a very small change, right? It's not a big change. So that's basically what we're starting to think about in this paper is, when we're talking about population health, we need to think about populations and not individuals. So for preventing highly prevalent conditions, injuries and fatalities due to motor vehicles, we need to think about that. And we also need to think about acting on features of the environment that aren't necessarily us, right? We need to think about how can we change the environment to make it safer for us as individuals. Oftentimes in health, we get focused on, well, we need to make people safer. Well, the people will come. The people will be safer if we change the environment, is my logic, right? So how can we change intersections, for example, to make them safer so that at the end of the day, people are safer? So that's concept number one, population approach. The second concept is the notion of vulnerable populations. And we can talk a lot about this in regard to the current transit lockout, but that'll be for the discussion. So the notion of vulnerable populations refers to groups who, because of their position in the social strata, are commonly exposed to contextual conditions that distinguish them from the rest of the population. So what does that mean? Basically, that means we have these social groups who are, I term them as vulnerable. You can think about new immigrants, you can think about First Nations populations, you can think about, any other examples?
Below the poverty line.
People of low income, older adults, right? We can think of a whole bunch of groups that we could term as vulnerable populations. And because of their exposure to contextual conditions, social conditions, environmental conditions, their risk for a whole bunch of different health outcomes is higher. Not just one. It's not like I'm overweight, therefore I have a higher risk for diabetes. It's I'm poor, therefore I have a higher risk for diabetes, overweight, you name them, right? All of these conditions. So we want to start thinking about that. So this is one of Pat's papers for his PhD. And this paper is entitled Neighborhood Social Inequalities and Road Traffic Injuries, the Influence of Traffic Volume in Road Design. It's published in the American Journal of Public Health. So in this paper, what they're looking at is road injuries. They use the ambulance data from the city of Montreal from 1999 to 2003 inclusively. And they include all road users. So again, we're talking about motor vehicles, cyclists, pedestrians, so on. So there's about 20,000 road injuries there in the ambulance data. And then they're using the Montreal Road Network intersections, about 18,000 intersections. The Origine Destination Survey, so that's the Montreal Household Travel Survey. Saskatchewan conducted a household travel survey in the fall of last year. I'm just getting my hands on that data, so that'll be fun. And they're using data from the 2006 census. So pulling together all kinds of data, road injuries, intersections, origin destination data to try to get an estimates of traffic volume and other types of things, and census data to try to paint a picture of road traffic injuries. So what they're trying to do in this paper is estimate the risk of injury at intersections for pedestrians, cyclists, and motor vehicle users, and examine socioeconomic status as an effect modifier between risk for each of those groups. So their outcome is a count of injured pedestrians, cyclists, and motor vehicle users, and they use a multi-level Poisson regression. So we have, we'll get to it. I'll explain it later. Okay, so we have this multi-level Poisson regression. Basically what they're doing is they have, at the level 1, at their outcome, they have an injured person, right? And then at level 2, they're using census data by dissemination area. Does everyone know what a dissemination area is? Yes? So a dissemination area is a level of census geography. It includes between 400 and 700 people. It's like a small neighborhood, a tiny little neighborhood with 700 people in it. And they use that to estimate social factors and so on, because they don't have the social factors in the ambulance data. They only have their injury, the ambulance came, and that's it. And they have a bunch of different models. We won't get into that too much. And here's what their findings show, basically. We're looking at the risk of collision by social group. So the richest is the reference category. I'm only showing quintile 3, so the middle group, and then the poorest group. So for pedestrians, cyclists, and motor vehicle users, we can see significantly greater risk among the lower income, among the more deprived groups compared to the higher groups, right? 3 times more likely to be involved in a collision for pedestrians, about the same for cyclists, and about 2.5 times more for motor vehicle users. And we also see our typical social inequality gradient, right? richest compared to the middle quintile, sort of our median group, middle group, there's still a significant difference between the richest and the median group for cyclists, pedestrians, and motor vehicles, okay? And this pattern repeats itself. We can see it here. So here we have each one of the models that Pat estimates. Here we see our classic income gradient, right? Event rate ratio about 6 times, so on and so on. This is the one we present. Model B, Model C. This is the one I presented just a minute ago. Okay, and basically what's happening here, you see that the gradient in social inequalities is decreasing, right? From the beginning simplest model and then adding different covariates in the model. Anyone hazard to guess what covariates are going into that model? What variables would explain and reduce social inequalities in motor vehicle collisions, road traffic collisions? What about the neighborhood?
Environment, population density, I think the traffic volume.
Right, so population density, traffic volume, intersection geometry. That means the type of intersection, whether it's got 4 stops, whether it's got 3 stops, whether it has two intersections, the sharpness of the corners at the intersections, so whether the intersections are really sort of curved or not, right? A curved intersection slows down traffic way more. You almost have to stop quite a lot more to actually turn your wheel to make the corner compared to a really curved intersection. And then also proxies for pedestrian volume. So pedestrian volume obviously is associated with the number of collisions. The more people you have, the more collisions you're going to have. So what can we learn from this study? Deprived neighborhoods in Montreal have more traffic, more injuries, more traffic, and more major roads. And as a result, they have more risk for pedestrians, cyclists, and motor vehicle users. I have 2 questions for you. I'm going to start with the second one. How would we explain this? Why would it be that in Montreal, poorer neighborhoods have more high-speed roads, more major roads, more traffic volume compared to richer neighborhoods? And then the second question is, are these results generalizable? Do you think that this result would be similar, Winnipeg, Regina, Saskatoon, having the poorer neighborhoods having more major roads, higher traffic volumes, higher speeds?
If somebody has an answer, please press the button.
Yeah.
Yes, I got the button. Well, I think people who have greater income tend to live out in the suburbs, have larger houses and lots. They're less dense. There's less traffic. And you find some of the core neighborhoods where you've got the condensed, higher density and higher traffic volumes. That's where lower income people live. So that's probably universal in most cities in Canada, at least in Western Canada.
Any other ideas? Yeah, button. Button. Did you push your button? Sorry. Did you push your button? Do you see the button? There you go.
So I believe that if you are rich, you just don't want to buy a house which is overlooking a motorway. So
right.
That's why. And I think it's mostly generalizable, except probably very small cities and towns where there is just, well, not enough place to choose from.
Right. Okay. I like that answer. That's a good answer. So what we see and what the further work that Patrick has done looking at sort of historical documents and construction of major roadways is that you do see that effect of, obviously, if you have more income, you're not going to choose to live beside a major road. But also, in the historical development in Montreal, in particular, of the road network, whenever the city tried to build a major road through a richer neighborhood, the neighborhood went, no way, this is not happening. Right? The neighborhood stepped up and said, we're not letting this go through our neighborhood, which led to sort of more winding roads, narrower roads, safer roads in the richer neighborhoods, and all of the freeways, all the busy roads in the poorer neighborhoods, because the people in those neighborhoods weren't able to advocate for that road safety, right? And we've seen that pattern. I think we see it in Saskatoon, and I think it's relatively generalizable. So that's idea 2, this idea of vulnerable populations and whether the road network itself is patterned according to sort of social factors. So the third thing we're going to talk about is co-benefits and co-risks. And this, we're going to start thinking about this idea of health impact assessments. So one of the big challenges that the people studying transportation and health have is that, generally speaking, transportation planners are involved in the planning of transportation. They plan it and they design it and they do it. But they're somewhat less interested in evaluating what happens after it's done. Whereas health people don't really care about the design part of it. They just want to evaluate it after it's done. So we're trying to balance a little bit that relationship between the design piece and the evaluating after it's done. One way that we can do that before it's done is this idea of a health impact assessment. So here we're trying to say, can we make some assumptions and project into the future what might happen if we implement a road network, or if we build a bridge, or if we have a transit lockout? So the World Health Organization defines health impact assessment as a combination of procedures, methods, and tools that systematically judges the potential and sometimes unintended effects of a policy, plan, program, or project on the health of the population and distribution of those effects within the population. HI identifies appropriate actions to manage those effects. So I would argue with this WHO definition, because I think by definition you can't identify unintended effects before they happen, but we'll stick with that for now. So here we're looking at a study on the health, co-benefits, and transportation-related reductions in greenhouse gas emissions in the San Francisco Bay Area. So we have a health impact assessment of what if we change to transportation usage in San Francisco, what would happen to certain health outcomes. So there's the first author, but the main guy, James Woodcock, he's at Cambridge, and he's doing some really, really interesting stuff with health impact assessment, transportation planning, transportation and health interventions. So the idea here is that what they're trying to do is use a modeling approach. It's based on the population attributable risk. So for my Western Regional Training Center people, what's population attributable risk? Anybody? Can you remember what it's supposed to do? Yep.
Okay, if there was some exposure which was causing the disease, what if we reduce the exposure? How will it affect the disease? So it's whether it's attributable to the disease or not in the population.
Okay, did everyone hear that? Okay, so if we have some exposure, if we assume that there's a causal relationship between exposure and outcome, what if we reduce that exposure, change that exposure? What would happen to the outcome when we did that? Okay, so this is the logic that they're using for these transportation and health impact models. So that's a big assumption, right? Assuming a causal relationship between some transportation thing and some health thing, but they're doing it anyway. So the objectives here are to quantify health benefits of transportation strategies to reduce greenhouse gas emissions. So it's important to notice that the health is not the main interest here. The main interest is transportation strategies to reduce greenhouse gas emissions. They're not talking about health specifically. Health is the co-benefit of reducing greenhouse gas emissions. They're not worried about changing health. They're worried about changing greenhouse gas emissions. And they're looking at, will anything happen to health if we attempt to reduce greenhouse gas emissions? So this model, this sort of approach that they use, requires basically 4 types of data in this case. Travel patterns and injuries, so essentially an assessment of risk of fatal and non-fatal injuries on whatever road network you're using, so San Francisco, Saskatoon, Winnipeg, what have you. Physical activity data, fine particulate matter data, that's your exposure to air pollution, and in this case they have greenhouse gas emissions. And essentially what they do here is they propose 4 travel pattern scenarios. Business as usual, do nothing. Low carbon driving, active transportation, and low carbon driving plus physical activity. So for San Francisco, the business as usual scenario projects year 2000 travel patterns into the future. Using travel demand models, it estimated an increase by 2035 of 5% of the 2000 baseline per capita mean daily vehicle miles traveled, so VMT, vehicle miles traveled for automobiles. So basically they're saying there's going to be 5% more vehicle miles traveled in 2035 compared to 2000. Low carbon driving, same assumption for vehicle miles traveled, 5% increase in 2035. But there's going to be lower carbon emissions because we're going to use more efficient vehicles, hybrids, light trucks, electric vehicles, and so on. So we're just going to reduce the greenhouse gas emissions through that. We're not going to drive any less. A short trip scenario, so that's an active transportation scenario. 50% of car trips less than 1.5 miles are walked, and 50% of car trips between 1.5 and 5 miles are bicycled. So that's a pretty strong assumption, right? Taking 50% of the 1.5 mile walking trips and car trips, and assuming they're walked, and 50% of the 1.5 to 5 mile trips are bicycled. And then a carbon physical activity combined scenario looking at both physical activity and reducing CO2 emissions and our physical activity variables there. So sort of trying to combine those two things. So what does that look like when we look at the study? Modeled estimate population distribution of daily, so active travel in minutes per day on the x-axis, 0, 50 minutes, 100 minutes, and population here. So basically what we see is that business as usual, nothing changes. So we have the same as that we have now, 4.4 minutes a day of active transportation. That's what it is in San Francisco. We hazard to guess in Saskatchewan what it might be. Less than 4.4 for sure. Okay, using our short trip scenario, we would increase from 4.4 to 12.4 minutes per day of active transportation. And using our carbon and physical activity scenario, we would go from 4.4 minutes per day to 22 minutes per day of active transportation. Does anyone know what the Canadian government recommendations for daily physical activity are? Cora? Yeah.
Well, they changed it from the daily. It's 150 minutes of moderate to physical or moderate to vigorous activity.
Okay, so 150 minutes
per week
of moderate to vigorous physical activity. Here we have 22 minutes per day. Multiply that by 7. We've made it, pretty much, right? So this would mean that everyone, on average, would be meeting the physical activity goal of 150 minutes per week. That's good. What about deaths and DALYs and years of life lost? So in our 3 scenarios here, our business as usual scenario, our physical activity scenario, and our 2 physical, this is wrong. This is our low carbon driving scenario. This is our physical activity scenario, and this is our low carbon driving plus physical activity scenario. With our low carbon driving scenario, we basically have almost no change in premature deaths, years of life lost, and daily adjusted life years. This is the population, so outcome is rate per million population. So we're reducing the number of premature deaths by 3 per million in the population. Then when we get to our physical activity scenario, we're reducing our premature deaths by about 300 per million population, and our years of life lost, about 3,000 fewer years of life lost per million population. And then daily adjusted life years are decreasing dramatically. And then we have a little bit of a change for our carbon plus physical activity scenario. So what does this mean? What are we talking about here? If we try to reduce greenhouse gases through interventions like active transportation, through low carbon driving, our main benefit, and this is not only this study, but basically every single modeling study of transportation changes shows that the primary benefit to health is changes in physical activity due to increases in active transportation, right? The risk of collisions, changing the risk of collisions can have an impact, but it's about 5 times lower than the change in physical activity. So the crucial thing that we're trying to do, that transportation interventions have the potential to do, is increase physical activity. And there's large co-benefits because physical activity is associated with a large number of chronic conditions, right? Our motor vehicle fatality injury relationship is really, really clear, right? You get hit by a car, you get injured. The mechanism is clear. Physical activity, the mechanism is less clear. You do physical activity, and that's associated with mental health, diabetes, blah, 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 a whole bunch of things. but we're not exactly sure what the mechanisms are that would explain all of those relationships. And that's arguably, I think, why physical activity is a little bit harder sell than motor vehicle collisions and things like smoking. So what we need to think about here is that transportation systems may have direct effects or maybe effect modifiers between health behaviors and outcomes. So our transportation system may directly influence our health, but it might also act through some other element to influence our health. And we also need to examine how health benefits and risk would be distributed in the population. So what haven't they done here that Pat did in our previous study? In theory, right, they could stratify by social factors and look at whether the benefits would be the same for our higher and lower income populations, for example, right? And maybe they would show that for the low income populations, the benefits are quite a bit less than average, and for the high income, the benefits are quite a bit higher than average. We might expect that based on the findings that we saw from the previous study that shows that in lower income neighborhoods, there's more busy roads, more traffic on roads, more major roads. So we talked about three concepts today: a population approach, vulnerable populations, and co-benefits and risks. So overall, would you agree with me now that health is associated with, that transportation systems are associated with your health? Yes, you already did. But one of the things that I want us to sort of try to start thinking about is that traditionally in health research, we're not that good, I would argue, at estimating co-benefits and co-risks. We're really focused on one outcome, one exposure, one outcome. But when we're thinking about things like transportation systems and physical activity, it's one change and the many different outcomes that we're trying to look at, and we have a hard time doing that. And I would say one of the reasons that we have a hard time doing that is we pay lip service to interdisciplinary research, right? It's really, everyone talks about it and everyone wants to do it, but every time I've actually tried to do it or someone has criticized me, it's because I do interdisciplinary research, right? So that's something that we really need to think about and do better, I would argue. There's one more thing I want to get us thinking about, and this is Rose, and this is sort of, we can talk about this in the context of our current transit strike, but also in the broader context of city of Saskatoon and lots of cities who are wanting to change or perceiving that a change is needed in transportation systems. And Rose says, if a problem is common and has been around for a long time, then people come to accept it even if it is large. It is the exceptional or new which causes alarm. The toll of deaths from road traffic accidents vastly exceeds that from crashing planes, but only the latter lead to public health inquiries, right? We're used to the risk of motor vehicles. Everyone's used to it. And we don't think about how impactful that is. 30,000 people die in the US of motor vehicle collisions, give or take. How many people die of airplane fatalities? 10, right? Very, very few. We can also add on the idea of social inequalities here, right? Social inequalities fall exactly into this realm. We're used to social inequalities. We've lived with them our whole lives. They're always there, and we have a hard time thinking about them. So with this comes a challenge to our political system to say, if we want to change something, but everyone says, oh, it's fine, we're used to it, then it's really hard to make a change, right? So we need to think about how we can sort of sell our arguments, basically, for transportation and health, in my case, to a political system to make change. That's all. Thank you.
Yeah, thank you, Dr. Fuller. Let's have one question for each side. One question in Saskatoon and one for the other side is Regina. Okay, and then Dr. Lisa Leaks. Is there any question here? No? Oh, one? Okay, let's go. Yeah.
All right, thank you for the presentation. I just want to kind of ask a question about your last slide, or your last, yeah. So if, I mean, in this case, if everybody gets to the situation or to the scenario, so what do you think is going to be the best possible approach to make sure that things are changed without, I mean, by going beyond the lip service that you talked about?
Right. So what's the best possible approach? I think there's two sort of I'm talking about two things at once here. First, I'm kind of talking about from the research side. So from the research side, like I mentioned, we really need to think about interdisciplinary research, and we really need to think about how we can better study co-benefits and co-risks when we have these sort of complex systems that we're trying to study. From a municipal sort of political perspective, I really think the crucial thing that a municipality needs to make changes to this type of thing is leadership. We've seen time and again that cities with mayors and cities with city councils who are leaders in areas like transportation are really able to make things happen relatively quickly, and we've seen that in lots of different cities. San Francisco is happening big time right now. London, England with Boris. Calgary is starting to move quite a bit. So those political sort of actors have made lots of changes happen. Does that answer your question?
Any question in Regina?
Hi. Can I just speak here? Okay. So I guess thank you for your comment about interdisciplinary research. So just a couple of questions or comments. One was that, as you Saskatchewanize your research, how do you factor in challenges like extreme weather for 4 months or living in a rural or northern environment? So how do you factor in, ability to increase physical activity and reduce injuries with those kind of situations? And then I guess the comment and maybe a question is the challenges with interdisciplinary research, but also the challenges in terms of investments in these kind of areas, because if the savings in, for example, the vast savings potentially in terms of preventing chronic diseases aren't really then diverted to investments in the built environment. So again, those are important policy questions that don't have easy answers, but I just wanted to make that comment in terms of research to help make those decisions at a government level.
Yeah, good. I think so. One of the big challenges that I find with this type of research is that one of the things I'm trying to do is make generalizable statements about the built environment and transportation systems. But if I go to a local city council or local city area and I say, well, there's been 20 studies published in the US and 2 studies in Canada and 5 in the UK that show that when you build a bridge, more people use the bridge, or when you build a bridge, more people walk over it and people get more physical activity. Invariably, what will happen when I go and say that is everyone will say, well, Saskatoon is different, or Winnipeg is different, or whatever city is different. All of those results don't apply. And it may be true, but it may also not be true. So I think as a researcher, one of the things I'm really trying to do is think about what can I present that I think is generalizable, and how can I make those arguments to say, no, I think this applies to Saskatoon, and then how can I sort of preempt the question and say, but Saskatoon is different in these 4 different ways, and we need to think about those. The winter, for example, is one that makes Saskatoon probably a lot different than San Francisco, for example. So that's one of the things that I'm always grappling with a little bit, is the need for sort of a local contextual research that might actually influence policy, and the broad sort of scientific objective of generalizing some results to a whole bunch of different cities, for example.
Dr. Lisa Leeds, do you have any question?
Yes, I do. Daniel, thanks a lot. That was a wonderful presentation. As always, you're such a dynamic speaker. I have a question about how you've incorporated use of health services into your research, or whether that's an opportunity for future research. When I look at what you presented on, it was around population health, but making that real too in terms of use of health services, for example, when you're talking to policy audiences, and the ability to link in data that focuses on health service use. Have you attempted that in any of your research, and is that an area that you're exploring, or are you going to continue to focus on the health of populations?
So you know, but the audience might not know. So some of the other things that I do are looking at social inequalities in health. I'm using health administrative data from the government of Saskatchewan. So that's sort of been a bit of the focus of my postdoc. And it is something that I'm really interested in trying to explore, is how we can link our health services data, which is much more reliable and probably valid than our self-report injury data or our ambulance data, right? But how we can try to link that health services data to other data sets like household travel surveys or like built environment city sort of level characteristics. So far, as I know, it hasn't been done. I was in Quebec City in August, and there's a researcher there named Alexandre Lebel, who's working on doing some of that for Quebec. One of the big challenges is all that health data is provincially regulated. You have to you can only do it within your province, or you have to have some data sharing agreements and whatnot to try to make more generalizable statements about health service transportation. One of the research questions that would be fascinating right now is what's the impact of the transportation lockout being on people's access or people's use of health services, especially in vulnerable populations, right?
Yeah.
It's a really good question, but I couldn't answer it today, but maybe I could if I had all the data, right?
Yeah, wonderful. Thank you so much, Daniel. I appreciate that.
Okay. Yeah.
I think it's a great point about sorry, the button has been pushed. I think it's a good point of municipal leadership around making some of these things happen, whether it's on a permanent basis or a pilot basis that we can study. A lot of the benefits that you highlighted, especially these health benefits, are going to be enjoyed, societally, but specifically by the province as a payer, by provincial governments. And a lot of the costs, both financial and political, potentially, are going to be carried by our municipal leadership. So everyone in this room is convinced that these are great ideas, but we know that I think as a case study, Saskatoon City Council might not be, and they're under the impression that their constituents aren't, obviously. So what are some of the cases that we can make in terms of the payoff at the city level that we might be able to bring to bear on some of those leaders?
Yeah, I think that's a hard question, but I think that one of the things that we have, like that all the cities have, is, for example, Saskatoon has its growth plan, right? And it has specific targets in the growth plan for reductions in motor vehicle use and increases in public transportation use and so on. So I think we really need to try to hold our municipal leaders accountable to those numbers that are in public documents and say, look, you're trying to get to this objective by 2035. It's probably not going to happen. And that's sort of another research project that I'm thinking about doing, is to say, okay, if we have this target to reduce motor vehicle use by 6% or 7%, I think it is, for the city by 2035, what are the steps that the city is taking to get there, and how likely is it that we'll actually achieve that objective, right? I would argue right now probably not very good, but you could try to do some estimates like that and say, if you want to get there, these are the policies that you need to implement, or these are the changes that you need to make in order to get there. Because it's really easy to put a number, right? Have a long-term objective and say this is the number, but it's harder to say year 1 will do this, year 2 will do this, year 3 will do this, and that will help us get there. Sorry, can I keep going? I think one of the other things is, like, I always waffle a little bit between being an advocate for transportation safety and walking and cycling and being a researcher, and I always end up with my researcher hat on for whatever reason. So I know that other people are much more likely to sort of jump into the advocate role than I am, which is okay with me, but I think we need a little bit of both.
Regina? No?
No questions here.
Okay, Dr. Giggs?
I'm good. Thank you so much.
Okay, and any more questions here? Okay, yeah. Did you push the button? Yeah.
Sorry, thanks. Thanks, Dan. I found it very interesting about the lower SES areas and the major roads, and we see that in our own city here with 22nd and 20th and that. This isn't a research question, it's more of an intervention question, if I may. But what would be your recommendation? Because I think of 22nd Street, if we traffic calm that, is that just going to displace traffic onto those local residential streets? So 19th Street will get worse, 23rd Street will get worse. Is there any kind of recommendations on how to approach that, so that area that's at higher risk for those residents, being in those higher deprivation areas, could benefit?
Yeah, I'm honestly so let's say we assume we traffic calm 22nd and we have more traffic going into the local streets. I'm actually okay with that, right? Because automatically you reduce the speed limit. 20th is 60. 22nd is 60. 50 or 60? 50? It's supposed to be 50. We know it's a lot faster than that, right? And a lot of the risk, where a lot of the risk comes from, is the speed. So comes from speed. So if cars are dispersed onto those other roads, the speeds will go down, and also there's more uncontrolled intersections. So everyone's just going a little bit slower because there's uncontrolled intersections you can't just sort of go through, right? The other thing is that most of our transit demand models, Kevin can correct me on this, assume that that all of our roads are saturated, right? So that's actually happening, so that people are actually using those small roads to get where they want to go. So I think that I would be okay with that. The other thing that we need to think about is we can't just traffic calm 22nd. That's just, we need to give people alternatives to get where they need to go without using a car, if we decide to traffic calm 22nd, right? The bus rapid transit program that the city is studying and hopefully going to implement in the next few years will have the unintended consequence of traffic calming 22nd, because one lane will be gone from 22nd, right? So we need to think about not only how we slow down the traffic, but how we give people the alternative modes of transportation that they need to get where they're going if they don't want to be stuck in traffic.
Any other questions?
Okay, I have one more question. It's Lisa.
Yeah.
Okay, Daniel, the WRTC students have been talking about interdisciplinary research and the skills that are needed in terms of being an interdisciplinary researcher. Can you talk about some of the things you have benefited from in terms of working with researchers from a variety of disciplinary backgrounds in terms of strengthening your own research program?
Sure, I guess. So one of the things that you probably noticed from the studies that I talked about is that the data sources used in those studies are really varied, right? We had ambulance data, we had geographic data, we had household travel survey data, we had all kinds of different types of data that we were bringing together to try to answer research questions. And one of the things that I found really crucial is learning about data from people from different disciplines. So my sort of original discipline is more like psychology. So I learned all of my sort of psychological research methods and stuff, then switched to public health, so then learned that, our epidemiological language, then learned geography, because obviously geography is a big piece of all of this that we're doing, and then learned sort of longitudinal and multi-level data analysis methods in a sociology department. So sort of tried to go through and found those opportunities that I was able to find, but learning to think about and talk about data from a whole bunch of different perspectives, I find has been helpful, because you know that if you hear a psychologist say mediation or moderation, you know how to translate that into epi, right? Or you know how to translate that into geography, because they don't use the same terms. So I think that's been one of the crucial things. And the other thing is, I guess, thinking about how your questions relate to other disciplines. So some colleagues and I wrote a paper a couple of years ago thinking about sort of public health as, we called it an interdisciplinary silo. So public health as a space where there's all of these disciplines that come together, but we rarely ever go and talk to the original discipline. So I do tons of geography, but I almost never talk to geographers. I talk to public health geographers who are public health people who do geography, but I've never talked to geographers. I never talk to economists or psychologists. I only talk to public health people who do those things. So that's something that I think people should try to get out there and actually talk to a geographer, and they have a different perspective than a public health geographer might have.
Wonderful, thank you.
Stephanie, you have a question?
Okay, so that's the part of the intro. So we call it iBikes, International Bike Share Study on Collisions and Physical Activity, or something like that. So it's an international study of bike share programs in New York, Montreal, Toronto, Washington, Chicago, Vancouver, Philadelphia, one more I think. And we're doing a repeat cross-sectional sample. So this fall we'll be doing the third year of data collection. So we sampled 12,000 people 2 years ago, 12,000 people last year, and 12,000 people this year across all of those cities. And we're basically looking at whether bike share programs change people's physical activity in the form of cycling and change their risk of collisions. We did the exact same study in Montreal, and we found that people cycling increased. So people were about 3 times more likely to cycle at least 10 minutes a week. Again, really small change, and that they were no more likely to be involved in a collision after the public bicycle share program was implemented. So not only were, on average, cyclists weren't more likely to be involved in a collision, but specifically users of the bike share program were actually safer than regular cyclists on their own bikes. So sort of trying to think about whether those arguments that when we talk about bike shares, basically, bike share users are more dangerous because they're uninitiated cyclists and they're not wearing helmets and so on and so on. We actually show that they're less likely to be involved in a collision. But if they are, we don't know if they're more likely to be injured severely because they're not wearing a helmet. We don't have that data. So.
No more question here? Okay. No, I think we are good. Thank you so much, Dr. Fuller.
Thanks, everyone. Thanks for coming.
Yeah.